my task today is talk about incidence and symptomatology related to ARIA after monoclonal antibody treatment in Alzheimer's disease. So these are my disclosures, and let's start from definition of what we mean by ARIA. So first of all, it's an acronym for amyloid-related imaging abnormalities, which already tell us that ARIA are MR signal abnormalities associated with the use of anti-beta amyloid monoclonal antibodies to treat Alzheimer's disease. We have two classes of such MR alterations, ARIA-E, which is composed by parenchymal edema and sulcal effusion, or ARIA-H, which are microhemorrhages and leptomeningeal superficial siderosis. Let's see some images in order to define better what is ARIA-E and what is ARIA-H. So ARIA-E stands for edema and effusion, and distinguished by anatomical location. So in edema, we have parenchymal signal abnormalities due to leakage of intravascular fluid and proteins into the parenchymal interstitial compartment, which results in such large lesions that in the white matter, which might also involve the gray matter, which is easily seen on T2-weighted FLAIR sequences. I wish to remind you that ARIA-E are very rare at baseline, so meaning that they show up during monoclonal immunotherapy of Alzheimer's disease. It is likely that they are really due to the effect of the drug. Effusion is instead sulcal flare hyperintensities, as shown here, where we have again water and proteins confined to the subarachnoid space. So we have increased MR signal on flare imaging in sulci, and they might be seen in isolation or together with edema, other large lesions involving the white and the gray matter close to the sulcal effusion. Regarding ARIA-H, they are due to either to microhemorrhages or superficial siderosis. So let's start from superficial siderosis. It is the typical aspects are curvilinear low intensities on gradient echo T2 star MR sequences, which are located at the surface of the brain. They are attributed to hemosiderin deposits, which are due to residual of a leakage from a vessel into the subarachnoid space or the periventitial component. And again, they're pretty rare at baseline. So instead, microhemorrhages are signal voids of usually below 10 millimeters in size, which are due again to hemosiderin deposits, and occur also there, occur infrequently, and this differently to what we said for other abnormalities, their association with ARIA is not well understood. So we saw some of the typical aspects of ARIA-E and ARIA-H, and so we can spend a few words on the symptoms and signs, which might be sometimes associated to such MR abnormalities. So there might be the development of acute or subacute new focal neurological signs or symptoms, which are related, of course, where the lesions are localized. Plus, we have signs of encephalopathy, which can be due to, which can result into headache, confusion, or in general altered mental status, dizziness, vertigo, nausea, vomiting, and so on. So we have a set of symptoms and signs which are focal symptoms and signs due to the location of the lesion, plus some signs of encephalopathy. So these are the meta-analysis of all of the ARIA findings in clinical trials with the immunotherapies for removing beta amyloid in Alzheimer's disease. I highlighted in red with the rectangular red lines those trials, those treatments that are closer to possible marketing These data are coming from a meta-analysis which didn't take into account, due to the time it was performed, phase 3 data results from lecanemab and donanemab. But as you could see, aducanumab is the one which is more frequently associated with ARIA-E and ARIA-H events. It is much less frequent in case of lecanemab, at least for the data we have up to now, as I said before, and both for ARIA-E and ARIA-H. And donanemab stays in the roughly in the middle between the two. At any rate, the overall pooled incidence of ARIA, of any sort of ARIA, is around 6 to 8% respectively. So ARIA-E is around 6, ARIA-H is around 8. As I said, it is much more frequently seen in people treated with aducanumab, but the vast majority, at any rate, of ARIA is in more than 80% asymptomatic. So we also performed a review paper in which a systematic review in which we try to understand whether there were some risk factors to develop ARIA a priori in order to stratify our patients and to reduce the risk of having such MR abnormalities. And what we saw in 2022 with the available data was that being carriers of ApoE4 allele is a fundamental way to increase the risk of ARIA-E incidence, as well as treatment dosage for all the treatments that were available at that time. At any rate, symptomatic cases account for a minority of events across all the randomized clinical trials, and the majority of ARIA resolves with treatment withhold. So meaning in general that ARIA-E manifests early during the course of the disease. So regarding ARIA-E, we can summarize that having ApoE4 and the treatment dosage are risk factors, but at any rate, this ARIA-E tend to form early during the titration phase. And the symptomatic events are relatively rare, less frequent than asymptomatic ones, and that usually resolve after treatment discontinuation. In the same systematic review, we also assessed the risk of having ARIA-H, and again, being carrier of ApoE4 is a risk factor, not treatment dosage, for all the randomized clinical trials. Again, also ARIA-H developed during the early phase of the exposure, and again, they are generally asymptomatic. So these are the data, the two phase 3 trials of aducanumab, Emerge and Engage, in which you have all the adverse events with an incidence greater than 10% in any dose group. And you can easily see that the major issues related to treatment is ARIA-E and the two forms of ARIA-H, with possible increase of headache occurrence due to the fact that when we have ARIA-E and ARIA-H, we might have headache as a symptomatology associated to it, as we said before, slight increase in falls, which again may be due to the encephalopathic condition. At any rate, there is nothing else appearing in these two phase 3 trials in terms of frequent adverse events apart from ARIA-E and ARIA-H. This is almost the same story as I said before, just seen in another from another perspective. So if something occurs with ARIA-E, it occurs during the first part, during the initial titration phase, and the risk is increased in people who are carriers of epsilon-4 allele of ApoE. This has been seen also in phase 2 and 3 trials of lecanemab, Again, being carriers of ApoE increases the risk significantly, despite the risk of ARIA is much lower in lecanemab-treated patients compared to aducanumab-treated patients, and this has been seen both in the phase 2 trial as well as in the phase 3 trial. Back again to emerge and engage, again to see the risk factors, and nothing new from this meta-analysis, in which you could see that again for ARIA-E. So this study has taken into account very many possible other potential risk factors, but again the two risk factors associated to ARIA-E is ApoE epsilon 4 status, as well as being carrier of having already macrohemorrhages on the baseline MR scans before treatment. Nothing was seen as a risk factor, a statistically significant risk factor for ARIA-H. This is a study with gantenerumab and solanezumab in people with dominantly inherited AD Alzheimer's disease mutation carriers, which were treated either with one drug or the other or in placebo. As you can see, again, the drugs didn't function, but they caused at low rate some ARIA-E events and some ARIA-H event. But at any rate, for ARIA-E, again, we had a significant trend for people being carriers of epsilon 4 allele, as well as the presence of macrohemorrhages at baseline. So there is consistent finding across different studies, which would allow us, when the drugs eventually will be marketed, to stratify people with different risks of having especially ARIA-E. Another aspect which has been developed is to try to define a severity scale, which was derived from emerge and engage data, in order to stratify the severity of ARIA abnormalities. And for ARIA-E is based essentially on the size and location of the lesions. For ARIA-H is mainly due to the number of abnormalities which can be seen, and this allows you to differentiate ARIA-A and the two forms of ARIA-H in mild, moderate, and severe. And this is fundamental to understand how the patient should be managed in case these abnormalities occur. At any rate, I wish also to remind you that by using this approach in emerge and engage, there were moderate ARIA-E events were the majority, so at around 60%, but more than 98% of them were in the 10 milligram per kilogram group, so the high dose group, and they resolved almost completely, up to more than 80% within 16 weeks after treatment discontinuation. There is also the possibility of a recurrent ARIA-E in roughly 10% of the patients, but this at high dose. But again, most of these abnormalities resolve after treatment discontinuation. Regarding whether these abnormalities are symptomatic or asymptomatic, I wish to remind you that the vast majority were asymptomatic, so 74%. 26% in the high dose treatment were symptomatic, but the severe symptomatology was just seen in 4% of them, with the typical characteristics that we have already discussed. So the point is that events can be prevented or can be anticipated by the presence of ApoE carrier status, by the presence of microhemorrhages at baseline, and in case these events occur, they are typically mild, they are moderate in roughly 50% of people with the high dose treatment, and the vast majority of the symptomatic events are mild or moderate, and only 4% are severe. So this brought regarding aducanumab, but this is likely to occur for other treatments, to define the characteristics of patient selection for future trials or individual treatments with such drugs. Of course, people should have clinically and biologically Alzheimer's disease, plus they should also perform a genetic testing to define the most important risk factor for having ARIA-E or ARIA-H later on. And of course, a baseline MR, especially to exclude hemorrhages, which are an additional risk factor, as we said. So let's say that we have data that reassure us, and we start to treat our patient with any immunotherapy for Alzheimer's disease. And I mean, there has been scheduled MR scanning in order to be ready to detect any ARIA it might evolve. So there has been proposals for having serial MR scanning. So, and this is the algorithm that we should follow in clinical practice. So we have a baseline MRI with no reason to exclude the patient for treatment from the treatment. And we perform serial MR scans during treatment. And let's imagine we detect either ARIA-E or ARIA-H. So if they are asymptomatic and they are mild, we will continue treatment unless something else happens, in which case we will discontinue it. We will also discontinue it if we have asymptomatic ARIA, but they are severe or moderate in terms of the classification that I showed you before, or if they are symptomatic, in which case you suspend treatment, you repeat MRI monthly. When you see a resolution of the events, you can restart treatment and eventually stop again if something else happens. So these are the take-home messages, the most important take-home messages of this brief talk, which I hope it was useful. So ARIA are a frequent finding in trials which used beta amyloid removal to treat Alzheimer's disease and monoclonal antibodies to treat Alzheimer's disease. They generally occur early in treatment curves, so we should think about that. If patients after titration is unlikely to have these events, there are risk factors which are clearly defined, which is ApoE epsilon force carriers, as well as macrohemorrhages on brain, baseline MR, and drug dosage, at least for ARIA-E. If ARIA occurs, they are typically radiologically mild and most frequently asymptomatic. If symptoms occur, they are typically signs of symptoms of encephalopathy. And we have also guidelines for ARIA monitoring during treatment in a real-world setting, which would allow us to treat our patients with much better care and I mean, trying to resolve the appearance of ARIA-E or ARIA-H in case they do show up. And as I showed you in the previous slide, we have very well established algorithms in order to decide when to stop and eventually when to restart treatment. So thank you very much for your attention, and I'm ready to take any question you might have.
Thank you for that talk. Our next talk will also be virtual on the pathogenesis of ARIA by Roxana Karari at the University of Southampton, UK.
Thank you very much to the organisers for the invitation, and many apologies for not being able to be there in person. My name is Roxana Karari. I'm a professor of clinical neuroanatomy based in the University of Southampton in the United Kingdom. And my task today is to talk to you about the pathogenesis of amyloid-related imaging abnormalities, or ARIA. My email is on the screen. Do please send me any questions because I will not be able to be present at the question and answer session. So in Alzheimer's disease, one of the prominent features is the deposition of amyloid beta in the walls of capillaries and cerebral arteries and leptomeningeal arteries as cerebral amyloid angiopathy. And with the confocal microscopy tools, we are able to demonstrate that the amyloid beta is present in tunica media, specifically in the basement membranes surrounding the smooth muscle cells. And then as disease progresses, it extends to destroy the leptomeningeal sheet and extend in the parenchyma. The structure of a cerebral artery is different in compared to the systemic arteries, in that, of course, the endothelium has a blood-brain barrier. In tunica media, there are several layers of smooth muscle cells, each separated by basement membranes, and that is where amyloid beta starts building up in Alzheimer's disease. And then instead of an adventitia, there is a leptomeningeal sheet derived from the arachnoid as an artery dives into the cortex from the subarachnoid space. And that layer in the cortex is closely adherent to the rest of the wall of the artery without allowing normally a perivascular space as such. Instead, there is a perivascular compartment formed by the basement membrane of the arachnoid layer and the basement membrane of the astrocyte end feet, also called glia limitans. So this way, the perivascular space is actually a perivascular compartment composed of the glial peel basement membranes. The extracellular space of the gray matter communicates directly with the basement membrane of a capillary, as you can see here. And the perivascular compartment formed by the two basement membranes of the glia limitans and the arachnoid layer is present in the gray matter. However, in the white matter and in the basal ganglia, there are two layers of arachnoid, and therefore there is a potential perivascular space. In the gray matter, there isn't. So in order to better understand the complexity of the pathology of dilated perivascular spaces and white matter hyperintensities, we had very well preserved biopsy tissue from a case of cerebral amyloid angiopathy in Queen Square from a patient under David Waring's care. And what we have seen, as you can see in the bottom part of the slide, is that the perivascular compartment is massively expanded. So it's been colored in green here. And the two layers of leptomeninges have actually been destroyed, allowing thus this amorphous space to form. So what you can see on the top hand side of the slide is from left to right a structure of an arteriole in the gray matter with the green endothelium, the yellow tunica media, and the red pia mater with the basement membranes in between them. So the red leptomeningeal layer is in a single layer in the gray matter, whereas in the white matter, as you can see in the middle picture, there are two such layers, creating thus a very important space that is present only in the white matter and in the basal ganglia. On the right-hand side, you can see these two layers without them being colored in, and we know we're in the white matter because we can see the myelin sheets. These are all specimens from very carefully preserved human tissue after biopsy. So in order to better understand the complexity of the drainage of soluble amyloid beta and fluid from the brain, we have injected carefully, and we have perfected this method of injecting tracers in the deep gray matter of experimental laboratory mice. And we have noticed that within 5 minutes, the tracer spreads in the extracellular spaces, and it enters the basement membranes of capillaries and arteries in exactly similar pattern as in human cerebral amyloid angiopathy. And we have called this intramural periarterial drainage because it is specifically in the walls of arteries. So, of course, what happens after immunization, and we have had the opportunity of studying the brains from the very first trial of immunization from Elan in the early 2000s, is macroscopically massive white matter abnormalities and hemorrhages, microscopically a worsening of cerebral amyloid angiopathy. And experimentally, what we have noticed is that immune complexes of antigen and antibodies form in the gray matter, and they form at 24 hours after the injection of the antigen in the human gray matter. And at that time point, the immune complexes are based in the basement membranes of capillaries and arteries, and they block the drainage of dextran, of tracers. They block it temporarily in normal experimental models, which of course does suggest that if the vasculature and the basement membranes are healthy, then IPAD does recover. What about IPAD in the white matter? Well, first of all, the white matter is poorly vascularized. There are fewer capillaries in the white matter compared to the normal gray matter. And then after the injection of tracers, the tracers tend to clog up in the capillaries of the white matter. So drainage is much slower normally from the normal white matter. So there has been a lot of work and modeling of the process of drainage of solubilized A beta after immunization, whether it's active or passive, and beautiful work from Roche Pharmaceuticals involving Roxane Aldea and Norman Mazur has shown that there are three possibilities. Possibility number one is that the solubilized A beta further blocks the already impaired IPAD and worsens CAA. Possibility number two is that the antibodies, of course, attack the cerebral amyloid angiopathy itself, creating thus edema, and in this case, the possibility of ARIA-H. And the third possibility is that the exaggerated immune response will also create local edema. From my perspective of the fact that intramural periarterial drainage reflects the drainage of amyloid, and its failure reflects exactly cerebral amyloid angiopathy, I would favor possibility number one, because as the leptomeningeal arteries are compromised by CAA, IPAD is impaired, and therefore the excess fluid will dilate the only spaces that exist around the arteries, which are in the white matter or basal ganglia, creating thus dilated perivascular spaces, white matter, hyperintensities, and ARIA-E. And with this, I would like to thank my group, my students, my late mentor, Roy Weller, AJ Verma, who has been an industrial mentor for a very long time. Of course, all my sponsors and my collaborators. And with this, I'd like to acknowledge Raj Kalaria in Newcastle, who's done an enormous work on aging of the cerebral blood vessels. Moni de Leon, of course, deserves no further introduction. He should be known by everybody in the field, especially neuroradiology, and David Waring, whom I already mentioned in London, and Masafumi Ihara in Japan. Thank you very much.
Thanks, Professor Carrari, for that talk. May I now invite to the microphone Professor Fabrizio Piazza from the University of Milan, Bicocca in Italy. And we'll be talking about Area E, Area H, and CA-related inflammation.
Good morning, everybody, and thanks for the invitation. So here are my disclosure. So what we learn about the meaning, the significance of Area E from the last 2 decades of trials experience. As we seen and learn from the 2 previous presentations, probably we'll learn more questions than answers. And here I try to recapitulate some of the main open questions that need to be addressed in the next few hours to ensure the successful of current monoclonal antibody use when they will be massively used in real-life clinical practice. So we don't know what is the significance, the biological significance of radiographic Area A. And in fact, there is no correlation, no clear evidence of any correlation between the pathological findings and the radiological findings, but it is quite known also because as a non-MD working in translational neuroscience, I talk every day with neuroradiologists and they continuously told me, Fabrizio, remind that we are not treating radiology, but we are treating patient and symptoms. Also, there are no correlation between the radiographic severity of Area E and the clinical severity or the progression, clinical progression in this patient. I don't want to read everything, otherwise we can waste probably 10 minutes just to read all these open questions. But what that is the key message here is that the main block road for why we have all of these unknown responses is because there is a known pathological mechanism of ARIA are largely unknown, and this is because we have no animal model for ARIA E, and because the samples and data from clinical trials are not publicly available for independent research. And this translates in the actual situation where we don't have any real biomarker for the prediction, the early diagnosis of the prognosis of and the treatment response of ARIA E and in clinical trials. So CAA-related inflammation, finally, after more than 10 years of research and experience, is emerging as the possible missing link to properly understand this mechanism and to be more successful in finding biomarker. And in particular, 10 years ago, we shown that in CAA-related inflammation patient, which is a rare condition happening in patients that show the same radiological findings as in ARIA E and ARIA H induced in clinical trial, we found that these patients have a significant increased amount of spontaneously produced anti-amyloid beta autoantibodies. And these autoantibodies, they return to the same level after the full clinical and radiological remission of the disease. And what that was also very interesting is that during the acute phase of the disease, when you have increased amount of this antibody, there is a strong correlation with the soluble circulating form of beta amyloid, about 42, which is related to plaques, and 40 that is mainly related to deposition in the vascular wall, so CAA. And the same happened for tau and phospho-tau. So during the acute phase, when you have increased amount of antibody, there is more presence of soluble form, and then when the antibody goes down at resolution, these beta amyloid form, they return to the same level found in AD and CAA. And it was also interesting to see that after each dose of corticosteroids, IV dose of corticosteroids, the level of this antibody, they comes down following each dose, returning to the same level at, after treatment. And we were also able to see and to parallel the findings observed in clinical trial, because these CAA-RI patients, they shown the same focal reduction of A-beta amyloid PET near radiographic ARIA-E. And so this, we suggested is related to the fact that ARIA-E may reflect the proof of an exaggerated drug engagement and effectiveness in removing A-beta plaques. So maybe it's too provocative, but maybe you need ARIA to remove plaques, but you need to be very close to the cutoff, which is this cutoff related to the dose of antibody, but you don't need to pass this threshold, otherwise you have the negative effect of ARIA. And in the subsequent year, CRI became an increasingly recognized disease, so probably is not so rare, and has been found also in cognitively normal odors, pre-symptomatic and genetic AD, and sporadic and AD, including minimally symptomatic CRI patients, compared to previous finding where they were only very dramatic and severe presentation. So CRI maybe is not necessarily restricted only to pure CAA patients. And so 2 years ago, we published the first natural history study and treatment-related outcome following steroid administration in patients with the CAA-RI from the real clinical practice in 110 patients. And what that we found is that we confirm all the same risk factor found in clinical trial, in therapeutic induced ARIA in clinical trials. So I'm blind and I cannot see here. One third of the patient had a history of MCI and AD, which was never reported before this prevalence in previous small case series or single case report from in CRI. And we also found that 37% of the patient presented with one single symptom. So the more we know the disease, the more we recognize, the more we are also able to early detect the disease, as in trial, when it is very mild or pouchy symptomatic. And that we confirm that the underlying disease is important because patients, they have microbleeds, but also less, 10% of the patient, they have just one or only cortical superficial siderosis. So, and also we reproduce the same prognosis in this patient as the vast majority of patients, they resolve within 3 months in our cohort. And so we suggest to use corticosteroids for the treatment of the disease. What was interesting, because when we look for prognostic predictor, we don't find any association between the MRI and clinical future and the prognosis in CRI. And so we start thinking that the course and the prognosis of ARIA-E is associated with the CSF concentration of anti-A-beta antibody and the immune-mediated reactivity that this antibody may induce. And so we designed this proof of concept study where we look longitudinally in a multimodal and multiparametric fashion, radiographic ARIA-E by MRI, and in vivo PET imaging of activated microglia with the TSPO tracer, and paired CSF testing of ATM biomarker and anti-A-beta antibody. And we also try to apply all the gold standard rating scale and system today used in clinical trials, such as the Salloway and the Barkov score. scales. And what we found is that during the subacute presentation of ARIA E in CRI, all patients had increased amount of anti-A beta autoantibodies that they return to lower level when the disease is resolved radiologically and clinically. But what that was more interesting is that by looking at the microglia PET activation, we found that although we found some widespread and low threshold signals in the brain, there were only few peaks of microglia activation on PET, and this peaks was very well associated with radiographic ARIA-E. But this association was found only in patients with AD plus CAA, and not in patients with only CAA, by ATN dosage, biomarker dosage, and MRI, of course, because these are the only armamentarium that today we have. And the other very important finding is that two patients, they develop ARIA-E following the first, ARIA-H following the first ARIA-E index event, and not concomitantly to the ARIA-E presentation. So we also find that the application of this radiographic scale applied today in clinical trial may not fully recapitulate and fully be used in real-life clinical practice. And I'm glad that we discussed this, Steven Salloway discussed this potential issue in the last 2 days, because we need previous scan to properly understand. And this one was not a clinical trial, was patients from real-life clinical trials, and most of these patients, they were completely healthy and unaware that they even have CAA before the CAA ARIA came out. So also, the fact that we found that these two ARIA-H occur after ARIA-E is very interesting, because confirm all the evidence that is very well reproduced in all the phase 3 clinical trials of these 3 drugs that has been approved or under approval. And in fact, the vast majority of patients, they develop both ARIA-E and ARIA-H, but 50 to 70% of the ARIA-H, they temporarily occur after the first ARIA-E index event, while ARIA-H only, so without ARIA-E, concomitant ARIA-E, equals placebo. So it means that this rate of ARIA-H is representing the natural history of CAA, and we are not going to reduce further probably with any antibody. But 70% of ARIA-E presented as asymptomatic and generally resolved within 2 to 4 months. However, 1/2 of these patients, they progressed to moderate, severe, and symptomatic presentation at continued dosing. And again, 10% of placebo had spontaneous ARIA-E. So is it correct to continue to call this presentation ARIA based on what we learned in the first presentation, or is better to call this CAA-related inflammation? And so based on all of this commonality that we collected in these years, we can I think that the field is ready and is recognizing that therapeutic-induced ARIA-E is iatrogenic CRI induced by the peak, the Cmax, the peak of this monoclonal antibody into the CSF, into the brain. So key question now is, are current MAS removing AD plaques at the expenses of an increased CAA pathology? We are treating AD, but we are at the same time accelerating CAA. And these are long, transient or long-lasting effect, and so we can also use corticosteroid. And so biomarker for ARIA-E and for the prediction, hopefully, or at least the early diagnosis of ARIA-E are very important, because with an appropriate therapeutic management, this means that we have the chance to avoid subsequent ARIA-H, which are probably the lethal consequences that we have shown in clinical trial in few cases. And also, these data, they confirm the ARIA paradox model that we presented, I think, in 2014 at the AIC in Copenhagen. And according to this model, the disassembly of plaques achieved by MAPS is causally linked to a paradoxical increase in CAA due to an exaggerated mobilization of beta amyloid, IPAT perturbation, as we learned from Roxana, and neuroinflammation microglia activation that can culminate with ARIA-H. And it is also very interesting that yesterday we learned that the monoclonal antibody for the soluble TREM2 monoclonal antibody has exactly the same rate of ARIA as all the other monoclonal antibody targeting beta amyloid. So this is also coming out in this meta-analysis, confirming that the balance between the effective treatment dosage and the safety of monoclonal antibodies will be very important in the next trial. And we believe that CSF testing for anti-beta antibody should be a companion diagnostic biomarker to assess risk stratification, drug tailoring, and dose monitoring in order to maintain a proper therapeutic window for the safe and effective clearance of beta amyloid in line with the precision medicine approach. And this is what we are doing with this registry that basically is paralleling the ALSNet registry in the US for patients treated with monoclonal antibody. This one is for ARIA, spontaneous ARIA, so CRI, and today we have more than 500 patients already collected. And we have 37 samples, longitudinal samples of paired CSF, plasma, serum, DNA, together with MRI, amyloid PET, and all the clinical data that are ready for biomarker testing and validation. And I'm lucky that I have also my daughter helping me. So I'm in Italy, we don't have too many resources. So this is the last slide. I think that we are entering in a second generation era of monoclonal antibody and trials for the immunotherapy. And we need increased knowledge on mechanism biomarker of ARIA because this is the most urgent international priority for the success of these drugs. Not only for a merely safety perspective, but also to understand how and why these antibodies works, and to increase the generalizability and to allow the inclusion of the broadened community of AD and CAA patients to receive this drug if it is enough safe and effective. And this is irrespective of current debates on the clinical effectiveness of MABs, because this represents already the current real life for patients. Only by working together we can do that, and so thank you all and all of you that contributed to the ICAB registry and in the obtaining of this data. And let me to thank my collaborator at the University of Milano Bicocca and all the network collaborators. Thank you.
Thank you, Dr. Piazza. It's good to see that scientific talent is lining up already. Moving on, it's a pleasure to introduce my co-chair, Dr. Kate Foley from Indiana University. We're talking about establishing glial responses to anti-amyloid beta immunotherapy.
Hello, everyone, and thank you for coming to our talk today. I'm Kate Foley. I'll be talking to you today on the glial responses to anti-beta immunotherapy and how our lab is trying to understand these responses to help target ARIA. This is preliminary data, so please no photo or videos, and I have nothing to disclose. So back in 2002, Pfeiffer et al. Released a one-page paper in Science showing that with anti-A beta use in older male mice, there was evidence of Prussian bleeding. This was increased in frequency and increased in severity with the anti-A beta trial. Similarly, in 2004, Dave Morgan and Donna Wilcock showed that there were Prussian bleeds, and these extended the longer the treatment lasted. So the longer the anti-A beta treatment, the more Prussian bleeds were present. So then when we moved into humans, the bapineuzumab phase 2 trial showed that there was increased vasogenic edema, and this increased by anti-A beta dose as well as ApoE4 status of the individual. And so in 2011, the Alzheimer's Association convened a research roundtable where they coined the term ARIA, amyloid-related imaging abnormalities. And as we heard, they split into ARIA-E and ARIA-H. And so we've had decades of research looking at the vascular dysfunction that results from anti-A beta antibody use. However, we still don't know the cause. So my hypothesis, starting my postdoc, was that glial cells contributed to these vascular damages after anti-A beta immunotherapy. And so in order to try and understand what these glial cells are doing and how the vascular is dysfunctional, we used 14-month wild-type and transgenic 2576 mice, or APPs, both males and females, and I did intracranial injections into the frontal cortex. I used either an IgG1 control or 6010, which is our anti-A beta antibody of choice. I then waited 24 hours or 3 days before brain dissection. And you might be thinking that 24 hours or 3 days is fairly quick. However, previous data has shown that with intracranial injections, the amount of total A beta, or these diffuse plaques, is significantly reduced at 24 hours, as seen here by the total A beta stain. However, it takes a little bit longer for compact plaques to be cleared as well. So for here, you can see THIO-S staining on the right, and in the anti-A beta group, it took not 24 hours, but 72 hours for those compact plaques to clear. So we stuck with these two time points in interest of what is happening at 24 hours and what is happening at 3 days. And so in order to understand these glial cell responses and how they may affect the vasculature, we did single cell sequencing analysis and digital spatial profiling. So the first vignette I'm going to talk about is the single cell sequencing analysis on a single cell suspension. And so we have 4 groups that we were looking at. All of them were APP genotype for anti-A beta or IgG injected, and we had 2 time points. And I was able to capture over 20,000 cells per condition. And as you can see on the UMAP on the right, we had 23 distinct clusters. And for the talk today, I'm going to focus on microglia. And so for here, I'm just showing 4 of the key genes that we looked at to help identify our microglia clusters. And there were 11 out of our 23 clusters which were positive for microglia markers, also highlighted on the right in the UMAP. And so my first question was, what is the difference between these microglia clusters at 24 hours? And so I have my control on the left and my anti-A beta injected on the right. And what I want to draw your attention to is the 3 largest clusters, 0, 1, and 2, which show differences between the control and the anti-A beta. So for 0 and 1, which are purple and dark blue respectively, there were more cells by increased percentage of those total cells in that cluster over all the cells captured in the control IgG group, and fewer cells in the anti-A beta group. However, cluster 2, which is shown on the left side in that light blue, showed more cells in the anti-A beta group with 14% compared to 1% in the IgG group. So these had great differences between the 2 injections. So what's happening with these microglia in these very different percentage clusters? So for cluster 0, which showed more microglia with about 19% in the IgG group and fewer in the anti-A beta group, I did genes go-term analysis. So I took the genes that were downregulated in this cluster and found that they enriched for cellular respiration and ATP biosynthesis, suggesting that these cells are downregulating cellular metabolism. I then took the upregulated genes in this cluster and found that they enriched for cytokine production and immune response, suggesting that they're upregulating their immune inflammatory processes. Cluster 1, which was very similarly located on the UMAP, showed very similar results, where there was a downregulation of the cellular metabolism and upregulation of these immune responses. And remind you that those were heavily favored in the control IgG group as opposed to the anti-A beta group. Cluster 2, however, which was on the other side of the UMAP, was the opposite, where we saw for the downregulated genes, the Go terms that enriched were immune response genes and motility. And for the upregulated genes, we saw increases in that cellular respiration that I just mentioned, suggesting that there is an opposing response here. And these cells in cluster 2, which were highly favored in the anti-A beta group, are favoring cellular respiration. So to bring this all together, I showed you that if a brain is injected with IgG, those microglia tended to favor immune effector processes and inflammation, and they downregulated cellular metabolism. However, if the brain was injected with the anti-A beta, those microglia shifted and instead favored metabolism-based processes and downregulated their immune response. And so all of this is happening at that 24-hour time point. So now the question was, what's happening to microglia after 3 days? Is there any change? And so while there is a lot of data here, I'm going to show you just highlighting cluster 2 and how this shifted. So now, if you can see, there is 25% of the cells in the control 3-day that are in cluster 2 and only 11% in the anti-A beta group. So what this looks like on an interaction plot over the course of the 2 time points is that there's an early activation of this A beta group, of this A beta injected group that's favoring metabolism and downregulating inflammatory response. But that response seems to be blunted at 3 days, where you see this giant increase in the IgG group. We don't know yet if this is a good or a bad response, or helpful or harmful. And so what we also did to complement this single cell analysis and understand what was happening in terms of spatial resolution, we did digital spatial profiling looking at proteins. And so here we took the other side of the brain and we stained them for GFAP, IBA1, and A beta. And for each brain slice, I drew 8 regions of interest. And so here on top of our groups that we have initially, we have areas of interest that have A beta or A beta negative, or were far or close to the intracranial injection site, which is denoted by the red arrow. And so for each region of interest, I then created a mask over IBA1 or GFAP positive cells, and those cells were split into different wells, and those wells were then analyzed for 35 proteins of interest. And like I said, today I'm going to focus on the A beta positive that were close to the injection site for IBA1 cells. And so while we saw no differences at 24 hours in protein expression of microglia that were near A beta and close to our anti-A beta injection site, we saw that after 3 days that there was SPP1 or osteopontin increases in protein expression in these microglia. And so if you're unfamiliar with SPP1 or osteopontin, this is primarily secreted by perivascular macrophages, and they signal to microglia to upregulate phagocytosis of A beta. And so we thought that this was particularly interesting, and we'll definitely be diving into it further. And so to wrap up, what I showed you is 2 levels at the RNA and the protein level to try and understand the glial responses, particularly microglia in this case, to anti-A beta injections, where we had an upregulation of metabolism from anti-A beta injection, and that seems to be blunted at 3 days. I then showed you that one particular protein of interest, SPP1, was upregulated in microglia that were close to our injection site after 3 days. And so as you can imagine, I have quite a bit more work to do. And so I'll be quantifying and looking at the microglia and astrocyte clusters for this data set for 24 hours and 3 days, also looking at the cellular shifts, and doing some IHC staining, which is ongoing, looking at GFAP, IBA1, 4G8, so those diffuse plaques, and compact Congo plaques. And thank you to the Alzheimer's Association, I am now funded to use a Model AD model of humanized APP that I'm going to cross with ApoE3 and ApoE4 to help establish these glial responses and how they may affect the vasculature. And so I'd like to thank my lab, Dr. Donna Wolcock and Erica Weekman, the past members and my funding, the University of Kentucky that has helped me get this project off the ground, and IU for being so welcoming because we moved there a couple weeks ago. Thank you so much. I now want to introduce our last speaker, Dr. Frank Walters from the Department of Epidemiology at in the Netherlands. Thank you.
Thank you, and thanks for the opportunity to speak here to the organization. I'll try to make up a little bit for lost time and switch here scopes towards more of the implications for ARIA on trial design and treatment considerations. And I want to focus here on two questions today with you, and that's one, responding to concerns that have been raised in several commentaries about the effect of unblinding due to ARIA on the trial validity, and then look a little bit towards the external validity of the trial, particularly with respect to ARIA, how that might influence the treatment decisions that we make in clinical setting when this is available. So not to disclose, I may ask you to refrain from any recordings here. So I'll first start talking about the unblinding. So as we've seen in the previous talks, there's a high incidence of ARIA in the RCTs, which preferentially occurs in the active treatment arms. And like I mentioned, there have been several commentaries in journals questioning whether this influences, the unblinding influences the estimate we have of the efficacy of the drugs. So as I'm also an epidemiologist, I'd like to visualize this in causal diagrams. What we try to estimate, of course, is the active therapy effect on cognition due to amyloid reduction. But what may happen is that the side effects give therapeutic insight and unblinding, and you can have some psychological treatment effects that affect cognition. However, we're not quite sure how big these effects are, and we're also not quite sure how big they would need to be to explain away the effects in the clinical trials. What we do know from other areas, of course, is that, say, in fields of depression or Parkinson's disease or epilepsy treatment, these effects can be quite substantial. So what we set out to do, and this is in collaboration with Dr. Jeremy Lebrecq at our institute, we tried to perform a simulation study to compute the magnitude of this psychological treatment effect required to explain the effects in the clinical trials. So what we did for that is we looked at the trials which met their primary endpoints. So we looked at Clarity AD, Emerge, and Trailblazer 2. And we looked up information from the published trial reports as well as the press releases and the presentations like the one you've seen the day before yesterday. So just to summarize quickly the overview of the trials, most of you will be familiar with the populations that were in these trials. What I want to focus on here is that for convenience, the trials have all a similar duration. That makes it easier to compare them. So I want to look here at the common endpoint. So this is the primary endpoint in 2 of 3 trials and the secondary in another. As you can see here, the treatment, both the changes in placebo, which are important for the modeling that we're trying to do here, as well as the treatment effects, are quite similar in Clarity AD and Emerge, and a bit larger, as presented earlier this conference for Trailblazer ALTS 2. What's also important is, of course, to which extent the incidence of ARIA leads to any unblinding. And I think here are the criteria for the safety protocol, showing that mostly with symptomatic ARIA and the substantial number of microhemorrhages in ARIA-H would lead to treatment suspension, discontinuation, or additional exams and visits and MRIs. We also see that across trials for moderate ARIA-E, and as you've heard previously in the talk, that's about 60% of the ARIA-Es in total, at least for Emerge. So here, just to summarize what you've seen earlier, as you see, the incidence of ARIA is quite high across trials, but I want to stress here also is that the ones that lead to symptoms and potentially are at higher risk of unblinding, then you see the incidence drops drastically. So for the symptomatic ARIA, for instance, the percentages are much lower than for any ARIA, of course, and that's the influence of the modeling I'll show you. The relative effect to placebo is something to take into account here, but more than the relative effect is the absolute effect between the treatment and the placebo groups, the absolute difference here that makes a difference to the modeling. So forward to what you see, as you can see here in the figure, the magnitude to explain, so again, to explain, fully explain the observed trial effects dependent with the unblinding, due to unblinding, depends on both the incidence of ARIA, respective to the placebo group, as well as the observed treatment effects. And that's why here in the graph you see different lines for the different trials, so representing the different treatment effects. And on the x-axis you see the difference in ARIA incidence between the treatment and the placebo. And as you can appreciate here that, for instance, for any area you would say that relatively small effects will suffice for common area, again, but most of these would be asymptomatic. So if you look at, for instance, emerge at the instance of any area, you see that, you know, about 1 point effect on the CDR sum of boxes would suffice, but again, most of these would not necessarily lead to unblinding. Conversely, if you look at the larger effects, look at the less common areas, so for instance, the symptomatic area, then you see here that large effects on the CDR sum of boxes, which easily reach 4 points, would be required to do so, making it less likely that such unblinding would actually lead to a full explanation of the observed efficacy estimates. Here you see the same numbers as you can extract from the graph, but then represented in a table. And again, you see here that for any area, these numbers are especially for emergent on a small side, but they quickly become much bigger and probably unrealistically high if you look at the symptomatic areas. I do want to stress here that the confidence intervals are as wide, so you have to take that into account also, that there is some variability here in the estimates. But overall, the takeaway here is that unblinding is unlikely, I think, to fully explain these treatment effects. So, if we presume assume these treatments are efficacious, then the natural question arises to whom we actually want to apply these treatments in practice. And I want to here focus specifically on the impact of ARIA on that. And what I'll show you is work led mainly by Jacqueline Klaus at our department. So we moved forward from a prior report that was published in JAMA about 2 years ago, which projected criteria for the eMERGE trial on Medicare beneficiaries, and showed that about 85 to 90% of patients with MCI or AD would meet at least one of the exclusion criteria, so not be included in the trial population. And it was substantially related also to the use of anticoagulant medication, about half of them. So the authors acknowledge that they make use of claims data and no availability of MRI, which makes it difficult to appreciate to which extent it's related to cerebrovascular disease, and it's undetermined for later trials. So we try to build on that by looking at this in the Rotterdam study population, which is an ongoing population-based study here in the Netherlands, with around 18,000 participants and 4 yearly center visits, which we also require brain MRI and cognitive testing. And what I'll show you here is results from the 5th examination wave between around 2010 and 2015 in people who underwent cognitive assessment and brain MRI. So what we did is we extracted the trial criteria, as I think most of you are familiar with, and applied these to the Rotterdam study population, so to a general population sample. And you see here a lot of similarities in, say, the age range and the MCI. I want to stress here that this is MCI regardless of etiology. We're still working on a subsample with PET imaging, but what I'll show you here is for any MCI in the population. We had detailed information on the medication use. And like I said, we had MRI criteria, which we tried to match as good as possible to the inclusion-exclusion criteria, say for the presence of lacunes, small vessel disease, etc. Note here that these MRI criteria are largely similar for the Trailblazer-ALZ-2 trial, with the exception that the lacunes and the infarcts were not defined as an exclusion criterion there. So what you see then is, like, of about around 3,000 participants, we had 213 with MCI. The age a little bit higher, I think, than in most of the trials, but fairly similar. And what we observed is that 1/3 of the population with MCI was on antithrombotic medication, so that's slightly lower than reported in the JAMA paper, but still, I think, substantial proportion, but majority on platelet inhibitors, so it excludes aspirin. What you also see, and that's depicted also in the graph here, is that 1/4 of those with MCI would be excluded on the basis of cerebrovascular disease, and that's really a variety of MRI markers that we see here that contributes to that, but lacunes, microbleeds, cortical infarcts, and also the predominant presence of severe white matter hyperintensity. But even without those, you would about lose about 18% of the population due to these criteria. Then the question is, how relevant is it that we don't include these people in the clinical trials, and how certain can we be that we can actually safely prescribe the medication in these individuals? And I think there's several considerations here. One thing I want to mention is that if we look in the trials in relation to antithrombotic use and the incidence of ARIA or microhemorrhages, we actually don't see that the presence of the use of platelet inhibitors or anticoagulants is not associated with a risk increase in the trial populations. And you can see that here, which was quite similar for platelet inhibitors and anticoagulants in both lecanemab and donanemab trials, which included people using anticoagulants. However, as we've also seen earlier, there is, of course, exceptional cases where this can have severe detrimental consequences that should be taken into account in these considerations. And I think it's also important to note here that, like I've shown you on a previous slide, a large proportion of individuals in the population with evidence already of cerebrovascular disease is not included in the trials and therefore not included in these populations, these analyses. Another thing I think to account for if we are going to look at to whom to prescribe this in practice is that, of course, we see a lot of ARIA-H in the active treatment arms, but we also see it in the placebo arms, and that might be in part reflective of the high incidence of microbleeds in the general older population. So one of the things that I think we do need to disentangle and tease out is to which extent the things that we are going to observe in treated populations in real practice actually reflect responses to the medication or are also in partly coincidental. So to conclude, I think the simulation studies help us to show that unblinding the ARIA is unlikely to fully explain the observed treatment effects. Of course, it can explain part of the effects, but may affect our judgment on perceived clinical relevance. I think, broadly speaking, these analyses are in line with sensitivity analysis censoring at time of ARIA events in the trials. And I do think we could incorporate additional measures in trial design to avoid this in the future, to make sure that it's not affecting our judgment. Moreover, I think patients with cerebrovascular disease are underrepresented in the RCTs, and I think the external validity in this group remains uncertain, and some caution then could be warranted. And just to stress, I think that comparative analysis of the trial data can be very helpful if we are to unravel these mechanisms and see how it aligns to our patients in real-world practice. With that, I want to thank the team at the Erasmus Medical Center Rotterdam, particularly Jeremy Lebrecht and Jacqueline Klaus, who contributed to this, and all the funders, of course. Thank you.
Thank you for that wonderful talk. We will now open it up for Q&A.
A lot of movement going on. I'm not sure if it's towards the microphones. Yeah, we have someone here.
Oh, okay. Microphone one, go ahead.
Yeah, Dave Morgan, Michigan State. Beautiful data you guys are collecting. And one question I have regarding the mouse study is, do you actually see an increase in CAA with the intracranial injections, much like we would with the systemic injections in the older mice?
That's a wonderful question, and the staining has been done and is currently being quantified. Unfortunately, not in time for this conference, but
Thank you.
I'll keep you updated. Thank you. And just a reminder, we also have Massimo on Zoom, so.
We already kindly answered some questions, I think. We have a question here at microphone number 2.
So John Ringman, the University of Southern California. It seemed, I guess it's a question for Massimo, that there was on one slide a non-significant trend for risk for ARIA associated with a history of hypertension. Is anybody concerned about that? Has anybody ever actually looked at the actual blood pressure in participants and the risk of ARIA?
Trend for hypertension and associated to ARIA, but not clear-cut association. So up to now, it is just the issue of dosing and ApoE. The rest is still to be defined.
Thank you.
All right, number 6.
Hi, this is Nancy Meserve. I'm with the Alzheimer's Clinical Trial Consortium Research Participant Advisory Panel, and I may be the only person in the room who is likely currently on lecanemab as part of the AHEAD prevention trial, and also has the risk factor of ApoE404. So this is first of all, thank you to all of the research that's gone into this, and a comment or an encouragement that because I think mainstream media is emphasizing the risk to ApoE4 homozygotes, I think it's incredibly important to not just dig down into ARIA edema, but to also look at what are the comorbid factors that in addition to ApoE44 would increase risk. And the reason I can say I'm probably on lecanemab is I have been a symptomatic ARIA-H person, and it has not kept me from doing anything, including coming to Amsterdam. So thank you.
Thank you for your participation.
That's one final question. Micro number 5, please.
Hi, this is Josh Cahan from Northwestern University. We know that not all cerebral hemorrhages are made equal, and as we bring these drugs out into the real world, we might run into individuals with known trauma and hemorrhages that match that trauma. Can you guys speculate as to whether we should be concerned about starting medications in that population? Maybe it causes immune priming that might lead to additional risk of ARIA, but it's really a big unanswered question that makes me concerned.
So,
If I can, so this is an important point again, but at present trials have excluded patients with previous trauma, so it's also one of the exclusion criteria, including the lecanemab trial. So I would think that in real life we should be very prudent. So I would suggest these patients to be not to be treated, at least up to now, and also the point of risk factor. So risk factor does not mean that you will have ARIA. Risk factor means that you have to increase your attention. So for instance, also including ApoE does not mean that patients should not be treated, but perhaps they should be followed up more strictly. So risk factor is not a cause of something, but it's just a risk factor. So we should be aware of risk factors. They will increase in the future with more experience. And then I would suggest this to lead to more strict, for instance, MR follow-up for these patients.
All right, thanks very much. I'm afraid we're already over time, so I think we have to call it a day and close the session for now. But if you have any other further questions, please come see the speakers that are here. I would like to thank all the speakers for their great talks here. Thanks for the organization for making this session possible, and of course you for your attendance and contributions. Thanks very much, and enjoy the rest of the day.